Good afternoon, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. Before starting this session, I would like to introduce the topic to everyone who is present today. For the today's session, we have the topic LFT updates 2025. What's normal, what's not, and what's next on the occasion of World Liver Day. For this topic, we have very eminent speaker. He is none other than Dr. V.S. Shankar Narayan, and today, sir is going to speak on that topic. So, to know more about this topic, I would like to invite sir and hand over this session to sir. Sir, the stage is yours. You can proceed from here.
Thank you, sir. The topic given to me, I wish you all the best of luck. And thank you very much for IGCP. The liver function test, clinical implications, and update. So, what's normal, abnormal, and future? It's not moving. 1 second. Lata?
Sir, click on that sir arrow, keyboard left arrow.
Arrow. It's not moving, man.
Keyboard arrow. Yes.
Right. What does the liver do? Let me go to the normal one. In a healthy person, the liver has hundreds of jobs, more than nearly 500 functions. Some of the most vital, which are very important in our practice, why everybody should know, cleans the toxins, particularly harmful substances, out of the blood, get rid of old red blood cells, makes the bile a fluid that helps the body to digest particularly the large volume fatty food, metabolizes the proteins, carbohydrates, fats, so your body can use them, produces substances to help blood clot, regulates the amount of blood in the body, and of course, it stores an energy, particularly very, very important and used by the body water. I may change my title. It is not liver function test henceforth. Why? The conventional liver test, it is a misnomer and a colloquial term and now obsolete. It's not effective to assess the actual function of many of the tests which we ask for, rather pinpoint the source of only the damage. Hemolysis, stress, lipemia, specimen integrity issues, erroneous results and interpretations are a big handicap. Not always specific for the liver. For example, I'll give you. If I ask for serum alkaline phosphatase and GGTP, they are not able to differentiate whether it is intrahepatic or extrahepatic cause for cholestasis. Total serum bile acid levels more than 10 micromole per liter. Specific and sensitive marker of ICP. But children with progressive familial intrahepatic cholestasis will have 10 to 20 times the normal bile salt concentration. It has limited information regarding presence or severity of any complication. Henceforth, the liver chemistry is test will be a better terminology, but no longer it's a liver function test. There's a change in the terminology. The liver chemistry test broadly, I will simplify it. If there is a damage and necrosis of the liver cells, I think I will ask the best indicator is ALT and AST. If I want to know whether the liver is functioning well, for example, if I am going to send the patient for transplant, I will ask for a synthetic function, and that is INR or prothrombin time. Now people are getting oriented to INR and albumin. If I face a child with high colored urine, pale colored stool, severe itching, deep jaundice. Maybe it indicates a cholestasis, intrahepatic or extrahepatic. So the cholestatic enzymes, particularly alkaline phosphatase and GGTP, and of course the bilirubin levels, conjugated bilirubin or unconjugated in hemolysis, particularly will help me. In addition, the synthetic function, particularly prothrombin time and INR and serum albumin, AG ratio will always help us. During my slides, I will touch upon these things. What is the value in clinical practice? I am not happy to have only this when I face a patient. I would like to ask for some more secondary biochemical liver chemistry tests. What are they? If a patient has got a chronic liver disease or acute liver cell failure, I may ask for a serum ammonia levels. Alpha fetoprotein is an indication, particularly in tyrosinemia diagnosis, particularly in hepatocellular carcinoma, and so many things. Carbohydrate deficient transferrin, which is a new thing, which I will touch upon at the end in future, and which says that CA19 is a very good tumor marker. Serum bile acids are supposed to be in primary biliary cirrhosis and of course in PFIC. Blood glucose level, you should not forget. Many of us ask for so many things, but in a diabetic and non-diabetic, in a sick liver, blood glucose falls. So it is produced only by the liver. Cirrhotic fellow may have serum sodium may be a factor which may show a hyponatremia. In cirrhosis, one of the biochemical clues that I will get is a persistently the depressed platelets. The thrombocytopenia is another factor. Now, in a nutshell, if I suspect a hepatocellular damage, ALT and AST will help me. If I have a patient with cholestasis, conjugated hyperbilirubinemia with cholestatic enzymes will be high. If I ask for synthetic function to tell us the prognosis in a given patient, I may ask for prothrombin time and serum albumin levels, and of course the albumin globulin ratio. GGTP is a special test. When compared to alkaline phosphatase, I will always prefer GGTP in liver chemistry test. Why? The reason is alkaline phosphatase may be high in any type of cholestasis. Elevated in cholestasis, and it's a very good indicator of a biliary obstruction. Low GGTP is an indicator of a PFIC 1 and 2. A normal or high level may indicate a PFIC 3. Bile acids, biliary obstruction, cholestasis, primary biliary cirrhosis, progressive biliary cholangitis, etc. 5-nucleotide is usually not done. I will not touch upon it. And LDH, very not always at war, but a hepatocellular damage. It's not a very specific one. The levels, you can always have it on your table in the office room, and you can refer it anywhere. But if the patient bilirubin level is more than 1 point in a newborn, then we may have to suspect. If it is more than 5 milligram, 20% will be conjugated. Normally, when you ask for a health workup, it is the unconjugated will be on the higher side when compared to the conjugated. Normal person is less than 0.3. The ALT, AST will be the better term. It's not, no longer we call it a GOTPT. And anything less than 40 is okay. Alkaline phosphatase, gamma glutamate, and again, if you go for anything maybe a variable in alkaline phosphatase because it is subject to the variation. Gamma glutamine is much more specific, particularly the biliary sensitivity. It has a more sensitivity to the biliary epithelium. Anything more than 30, you can call it as an obstruction to the flow. It gives you a flow. Regarding albumin AG ratio, which you all know, the normal appears to be 1.1, and the anything what you have is less than 4 milligram is we can call it as 3 milligram, 2.5 milligram. Clinical evidence is edema, and that will help you to confirm the thing. Of course, the albumin may be low not only in liver disease but also in other conditions, also like nephrotic syndrome, hypoproteinemia, etc., etc. Prothrombin time is a very good indicator of a synthetic function that indicates the coagulopathy, and you see the 10.9 to 12.5 seconds. But INR, anything more than 1.5, we cannot do any invasive procedure. The partial thromboplastic time is again a co-marker, and anything less than 35 may be abnormal. And of course, it should be more than that in all diseases. Serum ammonia, of course, is can be asked for, and leave it to the gastroenterologist and ICU people. The CBC will definitely help if there is no thrombocytopenia, and of course, or yes. If there is thrombocytopenia, then it indicates a chronic liver disease particularly, and pancytopenia is an indicator of a hypersplenism, which you may be getting it in extrahepatic portal vein structure. Individually, if I am going to discuss about each, I will rapidly just go through. If I want a total belly and unconjugated, conjugated is much more valid than the total belly and suggestive of a liver disorder, then prehepatic or posthepatic, which or hemolytic, that you can get it if there is going to be an unconjugated or conjugated rice. Unconjugated, if it is rice, then it indicates a prehepatic, particularly being water insoluble, is never excreted in the urine. So the urine bile pigment will be absent in these people. Clinically, mostly these people prehepatic, they have probably less than 5 milligrams of serum bile levels. Conjugated bile, increased levels indicates intrahepatic, extrahepatic obstructions, of course. Significant, it indicates a liver injury. I thought I have already shared, so that's a very important thing. Urine bilirubin, yes, normally absent, and of course seen in obstructive conditions, the biliary tract. Minimum amount is also hepatic conditions, intrahepatic cholestasis of severe diseases. Urobilinogen, normally present in the urine. Increased amount indicates prehepatic conditions or hepatic conditions sometimes, but more importantly, it is high, very high in prehepatic conditions. With reference to ALT, alanine transaminase, it is raised in indicator of a hepatocellular injury, and of course, is the aspartate transaminase is used along with ALT together for diagnosing damage, and AST is much more particularly more specific in these people to say. Alkaline phosphatase, value raised in various conditions other than bile duct also, diseases, cholestasis, bone disease, metastasis, renal condition, physiological during pregnancy in a growing child. A low alkaline phosphatase may indicate probably Wilson's disease. Not always, but you can expect it. GGTP, yes, raised levels indicate biliary obstruction, should be used along with ALP. Chronic alcoholism, particularly, is a very good indicator, particularly recently taken. The patient may deny, but this may show that he has taken it recently, increases the levels with hepatic enzyme induction. Drugs such as phenytoin, rifampicin also can cause a rise in this. Albumin, very good marker. Decreased levels indicate chronic liver disease. Prothrombin, synthesized by liver only. Prothrombin time increases in acute liver injury and, of course, end-stage liver disease. Level of albumin correlates with the prognosis. We have already told you because it's also a synthetic function. Prothrombin time and INR. If there is significant liver injury, yes. INR anything more than 1.5, it is an indicator that we should not do any invasive procedure, and anything more than 3 is a very bad indicator of a liver function. May go in for, particularly in paracetamol poisoning or chronic end-stage liver disease, anything more than 4 INR, people may take up for a liver transplant, unlikely to come back to normal. Blood glucose, yes, falls in hypoglycemia and glycogen storage disease, more for recurrent severe hypoglycemia, particularly in GSD type 1. Alpha-1 antitrypsin deficiency, there's no point in discussing because that is not seen in India. Please remember, my listeners, alpha-1 antitrypsin deficiency is not a alpha-fetoprotein. We have already told you malignancy, tyrosinemia, regenerating liver, etc. Chronic viral hepatitis, it may be right. Regarding platelets specifically, I thought I will share with you the most common hematological abnormality found in patients with chronic liver disease, particularly decompensated liver disease, persistently elevated one, and an indicator of an advanced liver disease. Now, with the summary, I have already told how am I going to make a diagnosis whether the in cholestasis, the alkaline phosphatase is enormously high. Alkaline phosphatase more than 3 times. The common causes could be, right, I would like to think about biliary obstruction, pregnancy, needs further assessment, and drugs, erythromycin is and the ALT phosphatase is a good indicator. The now infection, any type of virus, and both hepatotropic as well as other non-hepatotropic like EBV and CMI. Alcohol, yes, AST often more than 2 times the ALT, and fatty liver, and drugs, paracetamol, then metal overload, particularly hereditary hemochromatosis or Wilson's, hypoxia, autoimmune, etc. So these are the conditions. Probably we will think about hepatocellular ALT more than 3 times the ALP. Drugs. Liver monitoring is very efficiently, one has to monitor, and periodically you may have to do when a patient is before taking the medicine, during taking the medicine, after taking the medicine, valproic acid, ketoconazole, amiodarone, azathioprine, anti-tuberculous drug, methotrexate, dandrolene, thiocylidine, synthetic retinoids, chemotherapy drugs. All these patients who are on these drugs, one has to do a serial LFT to see that they don't get liver damage due to that. Now, any clue from biochemistry whether these fellow people are on that, they may have drugs history, vomiting, jaundice, hepatomegaly, etc. And if the patient has got a hepatocellular damage, the ALT is more than 2 times the upper limit of normal. Alkaline phosphatase may be normal. ALT versus AP increased more than 5 times. Cholestatic injury normal more than 2 ALP. Particularly alkaline phosphatase is more than twice, and alkaline phosphatase ALT AP ratio will be less than 2. Mixed, don't worry about it. Let's leave it to the gastroenterologist. Now, coming to the clinical aspect. When I have a patient in my room, clinically he is sick. I will ask for serum belly, conjugated, unconjugated. If the urine is clear, if the patient has got jaundice, if the patient do not have hepatomegaly, I will suspect unconjugated, may have splenomegaly. And the classical one where people treat, where you should not treat these people, it's a Gilbert's disease. Conjugated hyperbilirubinemia, if it is there, then I will ask for other things like cholestatic enzymes, like particularly alkaline phosphatase and hepatic cellular enzyme ALT, AST. Predominant elevation of AST and ALT, if it is there is a liver damage. It is hepatocellular. Classically, viral hepatitis. Predominant elevation of alkaline phosphatase is there, cholestatic injury or infiltrate. If they are normal, some of the inherited diseases like Dubin-Johnson or Rotar. Now, what about unconjugated? Unconjugated bili, if it is raised, when I would like to rule out a hematological, particularly I will do a hemoglobin and blood smear for spherocytes and reticulocyte count, which will be very high in these people. Then I suspect evidence of hemolysis. If it is there, hemolytic anemia or ineffective erythropoiesis. If there is no evidence of hemolytic biochemistry tests and this is absent, I may have to suspect Gilbert's disease, Gregson-George syndrome. I think I'm somewhat clear about my approach. Now, liver function tests, in short, hepatitis pattern, cirrhosis pattern. If the hepatitis is not controlled, they will go for cirrhosis, which is a chronic liver disease. And they may end up with end-stage liver disease for transplant. Total protein may be low in cirrhosis. Albumin will be low. Globulin is raised. AG ratio is less than 1. And of course, alkaline phosphatase may be 2 times the normal. ALT, AST, AST are increased up to probably 300. Particularly in viral hepatitis, this will be more than 1,000. Acute viral hepatitis. AST values increased into the thousands, but ALT is always than the AST and never greater than 300. This is what one has to think about it. What about adolescents? Yes, nowadays civilization, modern habits, everything is changed. People go and experiment so many things. They are happy. Once they start, there is no end. Alcohol use disorders. When will you suspect? What test is going to help me? In an alcoholic, AST to ALT ratio is generally it is 2:1. High level of AST activity in alcoholic liver disease. Elevated GGTP with AST suggests an alcoholic abuse and recently taken alcohol. GGTP should not be used alone since it is not very specific for alcohol. You have to ask for or combine with other function tests which I have told you now. Now, what about the fatty liver? Yes, fatty liver disease, non-alcoholic steatohepatitis, Nowadays, the terminology has been changed and it has been told as MSR and has recently gained more attention. The typical patient is always overweighted. He may have type 2 diabetes, dyslipidemia, and no evidence of alcohol. AST and ALT are usually both elevated with a ratio of 1:1, with other liver function tests being normal. Then you call it as steatohepatitis non-alcoholic. Biochemical change in metabolic associated liver disease, transaminases are elevated or may be normal. Alkaline phosphatase GGTP are both frequently elevated. And of course, triglycerides may be high, HDL may go down, LDL cholesterol ratio may be increased, which will indicate a future cardiovascular risk. Prothrombin time and albumin are also markers of hepatic synthetic function if the fat destroys the liver consistently. Low platelets in liver disease are often surrogate marker for splenomegaly and portal hypertension, but they can be suppressed in situations of bone marrow burden, including alcohol excess, iron overload, drugs, and validate. The metabolic syndrome and biochemical changes, particularly metabolic fatty liver disease patients attending a tertiary care hospital. That is a very good evidence which if you want, you can refer for that. Now, hemolytic jaundice. Now, increased bili, unconjugated, absent bilirubin in the urine, serum bili concentration usually less than 4 or 5, and direct bilirubin is less than 1.5. Lactic dehydrogenase, LDH levels may increase due to lysyl erythrocytes. AST, and of course, elevated aspartate. The levels may be elevated in hemolysis. LDH, AST ratio, don't worry about all those complications. When I have a patient with suspected hemolytic disease, clinically they have mild jaundice, splenomegaly, and the unconjugated bili will be high. Total bili may be less than 5. Urine is free from bile pigment. Urobilinogen may go up. Then osmotic fertility will help me to make a diagnosis, and genetic testing may help me for confirmation what it is. This, I think I have already mentioned. In short, if I am in the clinic, so far what I have told you, for all listeners who are practitioners, if they are fractionation is important. Then you know the normal level less than 1.5 or 1. Conjugatively is usually less than 20%. Now, if there is a conjugated hyperbole, I will ask for other tests. Then predominant elevation, hepatic injury, cholestatic injury will be predominant ALP. And if they are normal, then heritable conjugated disorders like Dubin-Johnson or Rota. I have already told you about this, how you make a diagnosis of Gilbert's, Crigler-Najjar, where everything will be normal. Only the bilirubin, particularly unconjugated, will be slightly high. They are variable. So this is a very important thing. And of course, with reference to intense jaundice in different conditions, I think mild rise, always suspect temporary problems, typhoid, malaria, dengue, leptospirosis, drug-induced sepsis. But if the if the hepatic enzymes, particularly ALT and AST, are abnormally high, more than 1,000, the conditions you should think of any type of viral hepatitis acute. ALT is more than AST. Metabolic like autoimmune, ischemia, particularly dengue shock, etc. Then, of course, the graft rejections. I have already told you these things. I don't think that I will go again in these. Alkaline phosphatase, high and cholestatic disorders, granulomatous disease, we have told some points there, because bone metastasis, infiltrative disease, and low in Wilson's, severe hepatic insufficiency, hemolysis, zinc deficiency, hypothyroid state. So that also may help you, but it's not a very often asked for test, though it will help you as a co-marker. GGTP is a very important marker, help to diagnose particularly cholestasis, PFIC, and in PFIC 1 and 2, it is low and high in 3. Figure out if there is a liver damage due to the liver disease or a bone disorder. When there is a doubt, and check for blockages in the bile duct. Screen or monitor alcohol use, abnormal autoimmune, particularly drink alcohol increases the GGT level. In general, higher the GGT level, better the damage. Proteins, particularly in CLD with portal hypertension, with jaundice, low volume levels, usually associated with ascites and edema. Reversal of less than 1 is very, very important marker in these people, both diagnostic and prognostic. If the result of total protein goes to the tests, further tests may be needed to investigate for the prognosis in a given patient. Prothrombin time, much more than that, is of course anything more than 3 seconds of control, and AST, ALT of more than 1, the biochemical clues for chronic liver disease, particularly am I dealing with chronic active hepatitis, including liver biopsy. If the INR is more than 3 in fulminant hepatic failure, it's poor, I am out to refer them for a transplant team. In case of acute viral hepatitis, if the enzymes are very high, but the prothrombin time continue to remain normal, prognosis and outcomes are supposed to be good. Clotting time of 25-30 seconds, of course, is normal. And PTTE, the number of seconds your blood need to make a clot, that test can be as along with prothrombin time. This I have already told you, but the most important thing in these people, if I suspect a chronic liver disease or a hepatomegaly, what I am interested is whether the enzymes are increased hepatocellular to suggest there is a steatohepatitis or hepatitis. But if I don't treat them, then the liver becomes firm due to fibrosis. Then it becomes nodular due to regeneration. So either any biochemical or any other non-invasive test, that then I may have to use a fibroscan, the fifth force, particularly parameter, a non-invasive screen use, AST, ALT, platelets to assess the liver fibrosis. The fifth scoring system is determined from the values of the patient age, platelet count, aspartate, etc. together. It's not our headache. They will give us the exact number. What I am interested as a clinician is fifth four, age into AST, etc. So how am I going to get the interpretation? What I am looking for, I will look for if the fifth four score is less than 1.45, it indicates absent cirrhosis. There is no cirrhosis. If it is 1.45 to 3.25, it is rather doubtful. We may have to watch and get a consultation periodically from hepatologist. If the FIB score is more than 3.5, 3.25, it indicates cirrhosis. Now, why am I telling this, particularly the FIB4 scoring system? It's a fibro score, which is an improvement, and that is going to be probably used everywhere and now being used when the patient is not fit for liver biopsy or defer liver biopsy. You can use this in practice. Enzymes are very high, as you've been seeing, more than 1000 ALT, 3500, 950 on regression. ALP is also very high. We may have to suspect acute viral hepatitis any type. Acute liver cell failure, INR more than 4. INR more than 4, total bili more than very high, age less than 2 years, total count more than 9,000. I think I might have to refer the patient, particularly paracetamol patient, from ICU to the transplant. I just give you more information regarding poor jaundiced patient. Baby 1, bili, the total is high, but the direct bili is very low. OTPDs are almost normal. Now, the protein albumin 5 point, but the protein is albumin is only 3. Alkaline phosphatase is slightly high. EGTP is low. It may indicate a breast milk jaundice. Baby 2 has got the direct bili is high. The OTPDs are almost 2 to 3 times above normal. Then the albumin is 3.4 normal. Alkaline phosphatase is very high. EGTP is very high. And if the patient has got fairly normal growth up to developing cirrhosis, no dysmorphism, and urine staining the diaper yellow, and stool is markedly pale persistently, big liver, then you suspect biliary atresia. Baby 3, the direct bili is high and OTPDs are high and albumin is low, alkaline phosphatase is high and DGTP is high. And if the patient has got skin lesion, particularly dermal erythropoiesis, which may be bluish in color, they suspect blueberry number muffin, and that is the indicator of a CME hepatitis. Baby 4, the patient, although if you appreciate the forehead is almost face with jaundice, then one has to suspect Alagili syndrome, and biochemical markers are almost like any other liver disease. These people, there's only condition where they have a murmur in the left upper border of the sternum, and that is suggestive of a peripheral pulmonic stenosis, better heard in the back. PFIC, usually diagnosed PFIC 1 and 2. GGTP is low or normal, and PFIC 3, it is high. Serum bile acids are raised in all, and the prognosis is very poor, particularly in PFIC 2 at the early onset. Biliary phospholipids, etc., we are not doing, and the GGTP is one of the important biochemical tests in these people. They come back. This particular issue, fever, jaundice, or less jaundice, high colored urine, fatigability, itching, and seen by many doctors. Diagnosis, parents much concerned. And of course, the viral markers are negative. Wilson screening is negative, and autoimmune markers are ANA positive, SMA positive, LKM negative. Then the serum IgG is very, very high. That's a very good indicator of a diagnostic screening test. An elevated AST, ALT more than 10 times the upper limit of normal may be there in these people. The doctors check the ALT, AST levels to follow the progress also in these people. Gamma globulin is at least 2 times the upper limit of normal, primarily IgG. The serological markers for autoimmune antibodies are positive, particularly ANA, SA. So that indicates if there is a increase of ANA, SMA alone, positive anti-smooth muscle body with or without, it may be a type 1. If it is anti-LMK or LKM, then probably, which is rare, and that you can get type 2. So this particular diagnosis we were able to make autoimmune hepatitis type 1 laboratory findings include the following. Wilson's disease is a very common metabolic disease. If you pick them up early before cirrhosis, I think it is reversible and Wilson curable, treatable. Wilson disease, especially we do see after 4 years of age, when they may have the particularly coughing, positive family or history. Ceruloplasmin is less than 20 milligrams and urine copper levels are more than 100. The minimum is 40. And particularly you have to do a spectrophotometry methods. These two lab findings with K ring positivities are enough for treatment. I do not want to go in depth about all the tests available for that, etc., the scoring, etc. Liver function test for Wilson's test may show most people have slightly abnormal liver tests. It may be reflecting upon varieties of liver disease, acute viral hepatitis, chronic viral hepatitis, cirrhosis liver, etc. And these people normal is less than 1. ALT ratio more than 2.2 indicates almost diagnosis of Wilson's. If the damage is significant, albumin levels go down, prothrombin time goes up. Gold standard test for diagnosing, of course, is the liver biopsy for liver copper, which is not usually done in many places, not available. You might have to get a separate container for sending the specimen. Now, any child with a chronic liver disease, if it is not treated from chronic hepatitis stage, when can I suspect a cirrhosis liver? The findings are platelet counts are persistently low, albumin is low, globulin is high, AG ratio again will help you. AST more than ALT, ALT and not fit or not willing for liver biopsy. I already told you, FIP score, particularly the 4, FIP 4 more than 3.5, 3.25 is almost, it gives you a clue. I already told you these things, particularly, I think I will not make my things. Ultimately, everybody is going to ask me, will my child be all right? What is the prognosis? This is what is very important. There are 5 parameters. Ascites, if it is there, yes. If it is no ascites, you give 1 point. If there is ascites moderate and easily treatable, 2 points. Then severe and intractable, 3 points. Encephalopathy, none. And of course, encephalopathy, sometimes it is there, history, and persistently evidence is probably 3 to 4. And bilirubin, normal, and very mildly raised and high. And you give points 1, 2, and 3. Albumin, normal, mildly variable, and persistently low, 3 points. INR, 1.7, yes, or 1.5. And of course, if it is less than 2.3 from 1.7, you give 2 points, and maybe more than 2.3, you give 3 points. Now, how are you going to interpret these points? The scoring is, of course, very easy. Clinically, if there is no ascites, no encephalopathy, bilirubin is almost very low, there is no ascites, albumin is also normal, INR is normal, probably I will just put it as Child-Pugh A, well compensated liver disease. Child-Pugh B, significant function, compromise the liver, which gastroenterologist will treat. Child-Pugh A, I think the physicians can do the job, treat well, maintain rapport with the gastroenterologist. Child-Pugh C is, we may have to hand it over to tertiary, particularly the hepatic transplant center, decompensated. So, this is a very important thing. Pediatrician should not be always pathologically minded. Normal liver chemistry test need not mean absence of liver disease. Periodic testing may help. In chronic hepatitis, well compensated cirrhosis, thing. Increase the serum bilirubin level less than 5. Gilbert's, particularly unconjugated. And then Sjogren's syndrome. The increase in growing children and rickets and mild elevation in myopathies, DM, particularly Duchenne muscular. Increased prothrombin time in vitamin K deficiency, ammonia in urea cycle defect, hypoalbuminemia in other extrahepatic causes like nephrotic, PLE, and of course, hypoglycemia and sepsis. All these things, the liver, the chemistry test need not always mean that there is a liver disease. It is reactionary that you may see that. Sometimes we may ask for periodic and repeated liver function tests in drug-induced liver disease, ALF, paracetamol poisoning, then persistent progressive jaundice, chronic liver disease like chronic hepatitis on treatment and autoimmune disease, acute cellular rejection, etc. We will have to ask for repeated testing. This is probably the last case I thought I will discuss with you. 8-year boy undernourished, frequently falls ill, investigated by pediatrician, many doctors in several institutes, including by an adult gastroenterologist. Started on empirical ATT due to positive manto by some doctor and also no improvement. Routine LFT 3 weeks after ATT was on the higher side. Serial LFTs they are able to give me. I just put it in one slide. The HOT is PT or high. SAP is also high. EGTP is normal. Albumin globulin ratio is normal. INR PT is normal. Synthetic functions are normal. That means the liver is not very badly damaged. Now, when you see this periodic liver test in this people, in the boy, then OTPTs are always elevated. They are not going to the level of thousands, etc. They are moderate elevation. Liver biopsy advised by an expert in an institute, patient deferred. They came to us very much concerned about child chronic illness, liver disease being treated. What is they have been asking? Sir, what is this going on? What is this? Will my child be all right or not? That is the thing. The diagnosis was chronic hepatitis when the child came to us. What we do? When we saw the patient, the parents are very much worried. We did a workup for hepatitis B, C, serum ceruloplasmin, ultrasound abdomen and at that time fifth fourth score is not available by Bruska, and of course A&E, ASM, everything was done. During consultation, child accidentally slips down from the fell down from a chair, and the child was not injured. The child fell down. The worried mother, why delay in diagnosis? What happened? Ah, as we see the child was getting up. I think you can make a diagnosis. The diagnosis, the classical sign is positive. He is able to walk ultimately. One clinical test. Thanks to the chair. What a change in the diagnosis now. Gover sign is positive. CPK we did was normally high. From chronic hepatitis to the muscle disorder. In children, creatinine kinase measurement. So in children, creatinine kinase measurement may help to determine whenever there is an isolated rise of ALT, AST. The final diagnosis workup is DMD, and happy for diagnosis, but unfortunately, we are sad for prognosis. Any further tests you need, I've just mentioned because the time up. Carbohydrate deficient transferrin test, CA19-9 is a useful monitoring for autoimmune disease, primary sclerosing, cholangitis, cholangiocarcinomas, etc. Serum ferritin levels are also being asked. Drug-induced liver disease, people are working up for R ratio. R ratio is ALT by upper limit of normal, ALP by upper limit of normal. Interpretation, if the R ratio is more than 5, hepatocellular injury. If it is less than 2, cholestatic injury. If it is less than 2 to 5, probably mixed injury. The next one, of course, is probably the ASLD has given some ideas for particularly the metabolic syndrome, which I do not want to go. It is a little away from the topic, but you can do how far the liver is bad. New test for cirrhosis, people, the fibro sure blood test. Probably it involves the combination of alpha-2 macroglobulin, hepatoglobulin, apolipoprotein, bilirubin, for you to remember all those things with the normal, etc., etc. See, ultimately the fibro score you in necro-inflammatory score, we want to be in the necro-inflammatory grade. People are using whether there is fibrosis or not. So I think I will end my talk here. I just wanted to share my knowledge with regarding the normal liver, normal values, the abnormal liver tests in different clinical conditions, what we see in office practice, and of course, at the end, something future where it may become very popular day by day with advances in. Thank you so much for the opportunity. Hello, sir. Hello.
Hi, sir. Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participant doctors who have joined this session, sir, on their practical approach to Sir, like as we know that, sir, this month is a World Liver Day. Like we are moving towards that, and you have given a very wonderful update on LFT. Sir, we have some questions, sir. With all your permission, shall we take these questions one by one?
Uh, Is there time? Roughly, yes.
Yes, yes, sir. The
I'll give
first
it to the
question I can
point.
see is from Dr. Subramaniam. He is asking, like, being a physician is very difficult to understand the proper liver disease. So, what will be the first approach to be done? Clinical examination preferred for the testing of after LFT.
Oh, the question is that what test? Scantia.
Sir, question is related to clinical examinations, like after performing the LFT, kidney function test. What are the things or rest can be
Kidney
done to
function test.
examine?
Kidney.
Yes, yes, sir.
Ah,
LFT,
see,
LFT, liver function test.
if the kidney is abnormal, is it?
Yes, sir. Yes.
Yeah, see, the liver and kidneys are both brothers. If the kidney is abnormal, the liver may be affected. If the liver is affected, kidney may be affected. When you see multi-organ involvement, probably you need to rule out a metabolic disease like Wilson's. That's where you make it in. Or think about some drugs which will renal toxic. That also has to be rolled out in these people. Clinical examination, you may have to look for rickets. Clinical examination, growth failure, pallor and anemia, dimorphic. And of course, these people are likely to develop early edema also. So, clinical examination in these people where you do a liver test in a sick liver kidney, I think one may have to do. There is something called very gross ascites, chronic liver disease, uncontrollable ascites, refractory ascites. These people are more prone for what is called hepatorenal syndrome. If that is not cured, they may go in for hepatopulmonary syndrome also. That's why we work up jointly with these two people. And why? Ultimately, they may go in for particularly dialysis. So, clinical examination, you have to look for particularly rickets, hepatorenal syndrome, and particularly other metabolic conditions and drugs.
Yes, sir.
Any other
Thank you, sir.
questions, sir?
Thank you so much, sir, for answering this question, sir. Like I have one feedback from Dr. Agniotri, and he has written very good topic, and thanks for this presentation.
Thank you so much.
Welcome, sir.
I thank you. Hot. I think we are going to meet again and again. Any
Yes,
topic
sir.
in
Yes, sir.
gastroenterology or in pediatrics, you ask me. I am also a teacher for pediatrics. So
Yes,
still
sir.
continue to
As
still continue to teach people at the age of 84. I'm just
great,
84.
sir. Great,
Yeah.
sir. Great, sir. Like,
Thank you so
sir,
much
I
for
like
the opportunity.
welcome, sir. We don't find any further questions, sir. With all your permission, I am concluding this session for today. With all your permission, sir.
Yes, sir. Thank you very much for
Take
celebrating
care,
World
sir.
Liver Day.
Yes, sir. And we would
Yes.
like to see
You
you
are
in future
very
also with
useful and
different topics,
successful.
sir.
Thank you, sir. Thank you. Right.
Take care, sir. Have a great day. Thank you.
Okay.